Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a young patient hit on the side of the head during sport or after a road traffic accident. They briefly lose consciousness, wake up and seem relatively normal, and then later become drowsy, develop a severe headache, vomit, and deteriorate rapidly. That classic story should make you think of an extradural hemorrhage, also called an epidural hemorrhage. Before we go into the pathophysiology, let us quickly revise the anatomy needed to understand this topic. First, look at the skull and its suture lines. These include the coronal suture, sagittal suture, and other junctions where skull bones meet. The important point is that the dura mater is tightly attached to the inner surface of the skull, especially at these suture lines. That tight attachment explains why extradural blood does not freely cross sutures. Now think about the veins and arteries around the dura. Bridging veins pass from the brain surface towards the dural venous sinuses. When these veins tear, they usually cause a subdural hemorrhage. In contrast, the meningeal arteries, especially the middle meningeal artery, run between the skull and the dura, often in grooves on the inner surface of the skull. When an artery here is torn, blood collects between the skull and the dura. That is extradural hemorrhage. So extradural hemorrhage means bleeding between the skull and the dura. The classic cause is arterial bleeding from the middle meningeal artery. Because this is a high-pressure arterial bleed, the hematoma can expand quickly. As it expands, it strips the dura away from the inner skull, forming a localized clot. The classic mechanism is blunt trauma to the temporal region. The pterion and temporal bone are relatively thin, so a fracture here can tear the middle meningeal artery. The sequence is temporal trauma leads to skull fracture tears the middle meningeal artery, arterial blood strips the dura away from the skull, and a rapidly expanding extradural clot forms. The shape on CT comes directly from the anatomy. Because the dura is tightly attached at suture lines, the blood is trapped between sutures. It cannot spread widely across the hemisphere in the way a subdural bleed can, so it forms a biconvex lentiform, lens-shaped, or egg-shaped collection. MRCP trap, extradural and epidural mean the same thing, and the classic CT description is a hyperdense, biconvex, extraaxial bleed that does not cross suture lines. Now compare this with subdural hemorrhage. Subdural hemorrhage is usually venous from torn bridging veins and is crescent-shaped or sickle-shaped. It can cross suture lines because it lies beneath the dura. Extradural hemorrhage is usually arterial, outside the dura, and is egg-shaped because it is limited by sutures. A simple memory aid is S for subdural and sickle-shaped, E for extradural and egg-shaped. As the extradural hematoma expands, it causes mass effect. Mass effect raises intracranial pressure and reduces cerebral perfusion pressure. If pressure continues to rise, the medial temporal lobe can be pushed downwards, causing uncal herniation. This is where the neurological signs become very important. Uncal herniation compresses the ipsilateral third cranial nerve. The parasympathetic fibers of the third nerve are affected, so the pupil on the same side as the bleed becomes dilated and poorly reactive or fixed. At the same time, compression of the cerebral peduncle affects corticospinal fibers, causing weakness on the opposite side of the body. So the classic neurological pattern is an ipsilateral fixed dilated pupil with contralateral weakness. The key clue is the combination of trauma, deterioration, raised intracranial pressure, and signs of herniation. Clinically, the famous pattern is brief loss of consciousness followed by a lucid interval, followed by deterioration as the hematoma expands. But do not rely on the lucid interval being present every time. In the exam and in clinical practice, any patient who deteriorates after head injury needs urgent assessment and imaging. Raised intracranial pressure may present with headache, vomiting, agitation, confusion, drowsiness, and reduced Glasgow Coma Score. As herniation develops, the patient may have an ipsilateral fixed dilated pupil and contralateral weakness. Late features include bradycardia, hypertension, and irregular breathing, reflecting severe intracranial hypertension and brainstem compromise. Diagnosis is with a non-contrast CT head. On the CT scan, you can see a bright hyperdense extraaxial collection, usually in the temporal or parietal region. The key visual point is that the hemorrhage is biconvex or egg-shaped. It bulges inwards towards the brain, but it is limited by the suture lines. This is the opposite of a subdural hematoma, which spreads more widely and appears crescent-shaped. When you see the CT, do not stop at naming the bleed. Look for skull fracture, midline shift, sulcal effacement, ventricular compression, and signs of impending herniation. These features determine urgency and help guide neurosurgical management. Treatment is a neurosurgical emergency. Start with ABCDE. Protect the cervical spine in trauma. Correct hypoxia and hypotension because both worsen secondary brain injury. Arrange urgent CT, perform frequent neurological observations, and reverse anticoagulation if relevant. At the same time, manage raised intracranial pressure. Elevate the head of the bed, provide adequate analgesia and sedation where appropriate, and use hypertonic saline or mannitol if there are signs of herniation while urgent neurosurgical treatment is being arranged. Definitive treatment for a significant extradural hemorrhage is urgent neurosurgical evacuation, usually by craniotomy. The goal is to remove the clot, stop the bleeding, relieve mass effect, and prevent herniation. Small, asymptomatic extradural bleeds may sometimes be observed, but only with close neurological monitoring, repeat imaging, and neurosurgical involvement. If you remember one thing, remember this. Extradural hemorrhage is classically an arterial bleed from the middle meningeal artery after temporal trauma, producing a rapidly expanding egg-shaped clot that is limited by suture lines and can cause uncal herniation. Quick recall. A patient has temporal head trauma, a brief loss of consciousness, then a lucid interval, followed by vomiting, reduced Glasgow coma score, and a fixed dilated right pupil. What bleed is most likely? Which artery is classically involved? And what is the mechanism of the pupil sign? The answer is extradural hemorrhage from the middle meningeal artery, with right third cranial nerve compression from uncal herniation causing loss of parasympathetic pupillary constriction. A CT head shows a hyperdense extraaxial collection in the temporal region. It is biconvex and stops at the suture lines. How does this distinguish it from subdural hemorrhage? The answer is that extradural hemorrhage is egg-shaped and limited by sutures because the dura is tightly attached there, whereas subdural hemorrhage is crescent-shaped, usually venous, and can cross suture lines. Do subscribe to the channel for further videos.